So if you guys would, I'm going to give each one of you a medication real quick, and if you could tell us what you know about it, names, indications for use, contraindications, dosages, routes, all of those exciting things. And then we'll get into the chapters, okay? So I'm just going to go down my list here, how you're listed in the in my meeting. So Natasha, you're up first. And
oh yay.
oh yay. So your medication is aspirin.
Okay, aspirin. Oh my God, anticoagulant. General dose is 324 milligrams, 305 milligrams, or 4 chewable 81, oral, under the tongue chewed. For peds, it's not indicated, can cause nausea, vomiting, heartburn. Contraindication is don't give it to them if they have a hypersensitivity to it, if they're allergic to it.
Okay. Any other contraindications?
Not that I can think of right now.
All right. Anybody else? Anybody want to jump in with any more
Bleeding disorders.
There you go. Bleeding disorders, recent
Oh,
surgery,
okay, yep.
those types of things.
Okay.
Hypersensitivity, absolutely. What was a medical problem that you should use caution with in aspirin administration? You guys
Strokes.
Nope.
GI bleeds.
Yeah.
What about a respiratory medical issue? You guys remember using caution with asthma patients?
Oh yeah, I remember hearing that.
Yeah. There's a small percentage of asthma patients that have a affinity to aspirin, and it will actually make their asthma excessively worse. So be careful with that. Anything else? Natasha, do you have anything else?
Honestly, no.
What's the indication for aspirin?
Chest pain.
Chest pain. Yep. So 324, 481 milligram chewables. This is PO. Oral, chew it up, swallow. And yeah, it's pretty good. All right. Moving along. Chris, you're up, buddy.
Okay.
So your medication is Ketorolac.
It's another pain reliever, another NSAID. You want to give 15 to 30, either IV or IM. Hypersensitivity to it. I'm drawing a blank on the other allergies to it or contraindications to it.
One contraindication to that would be if you know that they need to go to surgery.
There you go. Surgery.
Yeah, that's a big no-no.
If you suspect surgery's in their near future, don't give it because that'll delay it. So indication for use. It's used for moderate pain control. You said 15 to 30 IV or IM. That's the actual IV dose. It's a higher dose for IM. So it should be 30 to 60 for IM. It is an NSAID, so all the NSAID contraindications are in play. Very similar, but not exactly to aspirin. And then, as Derek said, with surgery in the future. What else? Anybody got anything else on this stuff?
Breastfeeding women can't give it.
Breastfeeding
Can't
women,
receive it.
right?
Or people who have renal disease.
Okay. What else? Anything else with this? What's the other name for it?
Toward
Toradol.
Toradol.
Yeah, there you go. All right. Derek, you're up next, buddy. You get naloxone.
you said naloxone.
Yes.
Another name for it is Narcan. Sorry. Stupid ass dog. Indication is respiratory depression, narcotic overdose. Contraindication is hypersensitivity. You don't want to give too much at one time because it could cause them to go into flash pulmonary edema, but that's of course going to be copious amounts. Supplied and pre-filled syringes, vials, ampoules. Dose is 1 to 2 milligrams nasally or 0.4 IV push.
Or ETT.
Okay, so there's a lot of routes for this one. So nasal, IV, IO, ET, IM, we can do a whole bunch of them. All right, respiratory depression due to narcotic overdose. So we don't really care that they overdose. We care that they can't breathe. And this will do it. So, how long for this stuff to kick in? Would you say?
About 3 to 5 minutes is what you're going to expect the window to be.
Okay, yeah, you should start seeing some changes in short order, if this is the deal. So, all right. Anybody have anything else with Narcan? Most people should be getting pretty good at giving it and using it, especially if you're working in or around Elizabeth City.
That's a fast tank.
Yeah.
Every shift is like.
Yep. They're just coming and coming.
Or the GSWs. Those are fun too, lately.
Yeah, those are picking up too. I mean, this is turning into Hampton Roads. All right. Mark, you're up. You get nitroglycerin.
All right, nitroglycerin is a vasodilator. Indications of it are chest pain of cardiac origin. The dose is 0.4 milligrams sublingual, and You could also use the paste, but that is based on the blood pressure, and you use like the length. Contraindications are low blood pressure, use of erectile dysfunction drugs, and I believe children. Children are definitely contraindicated. Side effects are dizziness, hypertension, headache.
Okay. You said that you could also use paste, and it was based on blood pressure. The length should be based on blood pressure.
Yeah.
Yeah. So typically, there's 3 measurements when you're doing paste. Your 3 blood pressure measurements are 100, 150, and 200, and those equate to inches of paste. So an inch and a half, and 2 inches paste accordingly.
All right.
What's another indication of use for nitro? You said chest pain, cardiac chest pain. But what's another indication?
CHF.
CHF. Yeah.
Right.
Yep. So that pulmonary edema is another good indication that you can use nitro. Vasodilate, give that fluid somewhere else to go besides the lungs. So there you go. Contraindications. What were they again? You said erectile dysfunction, something else?
Hypotension and
Hypotension.
children.
Yeah, that's right. So yeah, so hypotension, we don't want to give it to them because that's what we're gonna do. That drug is gonna cause that. So if they're already there, it's gonna make it worse. So there you go. Anything?
Why are children contraindicated?
I got children that are younger than 12.
What's that?
Children younger than 12.
Younger than 12?
Well, if they're having chest pain and then you do a 12 lead and it shows inferior, that's contraindicated as well, correct?
It is to some extent, because if they're having an inferior MI, nitroglycerin could actually cause a little more damage and a little more harm to the patient. So it's not a drop dead. You can't give it to them, but you need to be prepared for some things to happen. So in most cases, they just say don't give it to them, and a lot of people won't give it to them. But if you do, it's not the end of the world, but it's just some other things might happen. Let's see here. I'm trying to get you a good answer on the children part.
I mean, if I don't have an answer, it's all right. As long as I know not to give it to them.
Well, there's a reason why, so we'll figure it out here. I thought I had something. It does say children under 12. It does say anybody with increased intracranial pressure. I'll keep working on this. I'll get you an answer for the children under 12. What's up with that?
All right.
I'm not sure exactly what their mode of thinking is. It may be because they're already it may be a blood pressure issue.
That's what I was thinking, because kids' blood pressure is typically lower
Lower,
than
yeah.
adults.
Children blood pressures are lower, so it could be that could be the driving force.
Could it be their development too, Cliff?
I was thinking about that too, but I
It might
don't know.
stunt something.
Yeah, and I can't think of what it would be though, because it's just vasodilating for a short time. So,
So it won't mess with the kidneys or
well, I'm not going to say it won't, but everything messes with your kidneys, right? We're going to talk about that in a little bit. That's the best thing I got right now, Mark. But I'll keep looking while we're working here, and we can come up with something better.
All right.
Anybody else have anything with nitro? What about the medication itself?
Wear gloves.
Wear gloves. Absolutely. If you touch this stuff with your hands, you can get the effects from it. Also know that it's highly unstable, more so than all the other medications we deal with. So that's why it's in the the glass bottles. And that's also why it probably won't work a lot when you use it, because it's severely unstable. That is the one medication you got to pay attention to how it's stored. All right, Demetria,
yes, sir.
you get Epi 1 to 1,000.
All right. Epi 1 to 1,000 is a simple though-mimetic. The description is a bronchodilator, vasoconstrictor. The indication is allergic reaction, pediatric cardiac arrest, COPD or asthma. Contraindications: hypersensitivity, underlying cardiac disease, hypertension, pregnancy, and patients with tachyarrhythmias. Precautions: the patient should be monitored. Should be protected from light. Not the patient, the medicine. It should be protected from light. The blood pressure and the pulse and the ECG must be monitored. The side effects is palpitations or tachycardia, anxiousness, headache, and tremors. The dosage is 0.3 milligrams IM. And the pediatric dose is 0.01 milligrams per kilogram IM. The maximum dose is 0.3 milligrams for children.
So what are we using this for?
And anaphylaxis.
Okay.
And that's basically what I have.
Okay. Anybody have anything to add to this? How's this given? What's the
IM.
route? Yes. IM route. So 1 to 1,000, Epi 1 to 1,000, anaphylaxis is the primary use. Given IM, so adult dose is 0.3 to 0.5. Pediatric dose 0.01 milligrams per kilogram up to 0.3 max. Good deal. Crystal. Crystal, you get Epi 1 to 10,000.
I don't have any of my notes.
I'm not supposed to need them by this point.
Hold, please.
Do this from your
Look
brain.
here now. Okay. Hold on.
Come on, girl. Tell us what you know. Indications, contraindications, routes,
Epi 1 to
dosages.
10?
Yes, Epi 1 to 10.
You said Epi 1 to 10?
Yep.
Okay, it's a nitrate vasodilator dosage. Hold on. No, I'm like, I got the wrong one. Hold on a second. That's nitro. Cardiac, right?
Say who what?
Nitro 1 to 10 is cardiac.
Epi 1 to 10.
Can you just come back to me?
You're the last one.
So I can pull up. I'm the last one.
Yep, this is it.
Okay. 1 to 10 is cardiac. Was it 1 milligram every 3 to 5 minutes?
Yes.
So you
What's
can't put
the-
me on the spot like that, man.
What's the indication for use?
Cardiac arrest.
Okay. Any contraindications?
Oh. I mean, if they have a pulse. Hold on.
There you go. People that are not in cardiac arrest.
Good job, Crystal.
Way to go, Crystal.
She did good.
Yep.
Look, I'm multitasking like a bitch right now, okay?
Hey, girl. Way to make company.
She's crazy.
Anybody have anything to add to Epi 1 to 10? Cardiac arrest, 1 milligram is the dose. What's the routes? We didn't talk about routes.
I am.
IV.
Okay. IV or IO?
IO.
IV or IO be preferred routes.
Or the
Right.
ET2.
You can do it down the tube.
But you have to double it.
Yeah, double the dose and flush behind it, and then and that'll work as well. So we're not IM for Epi 1 to 10. So this will be an IV or IO route, preferably, or an ET route. So if you're intubating them. All right, so just a little quick med refresher for you guys. Keep thinking about these medications and looking at your cards, because we're gonna keep talking about them. You're gonna keep using them even when you get on the ambulances. So keep on keeping on. Any questions? If not, we'll start into the chapters tonight. Again, 24, 5, and 6. We're doing 3 chapters this week. So we'll be talking about abdominal stuff, reproductive and genitalia stuff, and then blood stuff, hematology. So different problems, issues, how we're gonna handle them, what we're gonna do for them. You'll be surprised. at what we can do for them. First chapter up tonight is the abdominal chapter. So we're going to talk about abdominal and GI situations, emergencies, problems, those types of things, and how we're going to handle them at the A level. Just like all the other chapters, this chapter starts with an A and P section, so anatomy and physiology, get you familiar with what's going on. Same as in your EMT class and your AEMT class, the anatomy doesn't change. If you guys move on to paramedic class, the anatomy still won't change. Your abdominal section is going to be divided into 4 quadrants, and that's how we refer to them, 1, 2, 3, and 4. So based on their regions, it's good to know what organs are found in each one of those quadrants and what you can expect as far as issues with them. So if you're not familiar with the abdominal layout, they've got some nice pictures for you. They break it down into the 4 quadrants, and they even list all of the important details in each quadrant, so you'll know which organs and body parts fall in those. So take some time with that part if you're not good on it yet, and then you'll be better than you are. All right, so the biggest thing coming out of the abdominal region is pain, right? We hear about abdominal pain a lot, and we have to figure out what that pain, where it's coming from, what's causing it, and that sort of stuff. And for us in the field, that's a little difficult. But if you've got a good understanding of the regions, of the organs, what their functions are, what they do, which ones are most likely to be problem children, then I think you'll do well in trying to narrow it down or come up with a field diagnosis about what's going on with the patient. So we'll just go quadrant by quadrant through the abdomen and talk about the pain and what likely things are happening. So first and foremost, your book talks about 3 different kinds of abdominal pain. They have visceral pain, then they have parietal or somatic pain, and then there's referred pain. The referred pain is probably the one that's the weirdest because it's going to be pain in a region that's remote from where the actual cause is. So it could be something like I think the most weirdest of the pains is a gallbladder issue. If you have gallbladder pain, then most of the time your gallbladder is located in the right upper quadrant, but that's not where the pain will be. A lot of people will experience pain in their back between their shoulder blades with a gallbladder problem. So if they develop gallstones, they have those problems, it presents itself as pain, but in a lot of cases it'll be pain in their back, up in their shoulders or between their shoulder blades. So that is referred pain. And it is quite often difficult to diagnose or even come up with a good reason or a good problem for it. Parietal or somatic pain, that is a flare up from the peritoneum, and that if you guys are familiar with the peritoneum, it lines the abdominal cavity. So that'll flare up. Typically, if that does happen, they're going to have sharp pains, and it could be anywhere. So they can pinpoint where the pain is, but it could be in any region, and there's no real clear definition as to why it's flaring up, but you'll have that. In most cases, in both of these situations, we're going to be in a supportive care mode for these folks, simply because we don't know what's really causing the pain. But we talked about Toradol earlier as one of our pain management choices. We have Toradol, we have acetaminophen. Neither one of those is a real good option here. Acetaminophen or ibuprofen probably isn't going to touch their pain. But with the Toradol, we're not real sure what's causing the pain, so we're worried about them needing surgery or having to delay surgery, and I'm not so sure that this is a great option for them either. So most cases with these, it's going to be supportive care and a good assessment as we take them in. The visceral pain, that's coming from organs in the abdomen. So one of the organs is having an issue. It's presenting the pain. The problem with visceral pain is that the patient is going to have a hard time identifying a location for you. So it won't be as clearly defined as the parietal pain. They'll be able to point right to it where it is with parietal pain, but with the visceral pain, it's kind of going to get lost in translation from the organ to the outside of their abdomen where they can actually tell you it hurts. So it's going to take some good detective work from you as you do your assessment. Lots of questions. Lots of poking around and pushing, seeing what you can find to figure out where it's actually originating and what your options are. So we'll start at the top, work our way down. Left upper quadrant. What's the remarkable items in the left upper quadrant?
Stomach.
Okay.
Liver.
Gallbladder.
That's in the right.
Left upper quadrant.
Oh, left.
Left. Your other left.
I think part of the pancreas. The pancreas is more central.
Okay. So we've got stomach, part of the liver, part of the pancreas, colon. Yep. Couple more things.
Liver.
Yeah.
Liver, part of the liver.
Mm-hmm.
Left kidney.
Kidney.
The left one.
Yep. One more thing.
The pancreas.
One more thing.
Spleen.
Spleen. There it is. So a good handful of choices in the left upper quadrant. You know, you've got a good section of the liver, part of the pancreas, because they span across both upper quadrants. The colon also spans the upper quadrants, and then you have the stomach, the kidney, and the spleen, which are unique to the left upper quadrant. So those would be the first three to focus on because they're the only ones in the left upper, and then all the rest of them kind of span across boundary lines. So what about the right upper? We know we got the liver and the pancreas. because they span across both, as well as the colon.
That's where the gallbladder.
Okay, gallbladder's over in the right.
Part of the colon as well.
Yep, colon's spanning over. One more thing
right
that's in the
kidney.
right. Yeah, the right kidney, that's over there in the right by itself. So a couple by themselves, the kidney, the gallbladder, and then the rest of them, liver, colon, pancreas, all of those are spanning across those boundary lines. We'll come on down, right lower.
Appendix.
Appendix.
Small
Okay,
intestine.
small intestines.
Major arteries and veins to the right leg.
Yep.
Part of the colon
Yep.
and the small intestines.
So small intestines, large intestines, which is the colon, they're there. You guys hit on the primary little thing, which is the appendix, which is at the tail end. That's the little piece at the tail end.
Is the cecum there? I think the appendix is attached to the cecum,
Yeah,
which is
yeah.
part of the large intestine.
Yep, that's right there at the at the one end of it. And then this is where the major vessels bifurcate here in the lower abdominal region. So you've got those large arteries and veins that are coming down or going up, and so as the aorta comes down through the abdomen, it's going to branch off and go down each leg here in the lower abdominal region, as well as the femoral veins. You're going to see those branching off and heading down into the legs as well. So some big blood vessels. These are some big vessels, and you're also getting into your left and right ureters from the kidneys that are heading towards the bladder, which is the bladder's kind of centralized. So technically, it does cross the regions between right lower and left lower. All right, so then that takes us to left lower. What's over there? Anything else over there that we haven't talked about yet?
Nothing but urea.
Yeah. Right. So you've got your intestines, which take up most of the space, and they and they're actually present in all four regions. So there's issues that can arise with those throughout the regions, and then most of the vital organs are going to be found in the upper two regions. So the lower two regions are mostly intestines and bladder and large vessels. So keeping those things in mind as we go, we'll talk about some issues, and hopefully you can work your way through them, knowing where things are. Your book does talk about the esophagus, and it's obviously not in the abdominal region, but it does connect to the stomach, which is in the abdominal region. So there are a couple issues that happen with the esophagus that could be quite taxing on you if you have to respond to these folks. And so two things that can happen with the esophagus. One is esophageal varices. and the other is the Mallory-Weiss tear. So if you deal with either one of these, and especially with the varices, you are going to see an incredible amount of blood like you've never seen before. So just be prepared for that. Esophageal varices are like varicose veins of the esophagus. So if you've ever seen someone that has those varicose veins in their legs, these are big swollen veins that are protruding. They're under pressure. And the problem with varicose veins is that when they rupture, it's hard to get the bleeding to stop. And pressure bandages are required, but extensive pressure, and it takes a very long time to get those things to stop. With esophageal varices, when those veins rupture, these people will start vomiting blood violently. And it will be a ton of it. You will think that there's no way they can have any blood left in them when you see what comes out of there. So be prepared for that. Who's at most risk for that? What type of people?
Alcoholics.
There you go. So alcoholics, very high risk, and when they start vomiting up copious amounts of blood, you can suspect that that's the problem. And then the Mallory-Weiss tear is usually caused by violent vomiting. So that's just a tearing of the esophagus lining, and it will also produce quite a bit of bleeding. So while we're here, let's talk about GI bleeding. Typically, we associate GI bleeding in two directions. We refer to it as upper GI bleeding or lower GI bleeding. What is the difference, and how do we know?
The color of the blood.
And say lower is like coffee ground, right?
Mhm.
And upper is bright red. Or do I have that back?
I think you got that backwards.
Oh, okay.
Lower is bright red,
Bright red.
and upper is emesis color,
There you go.
like stool color.
Yeah. Lower GI bleeding usually comes out in the form of red blood, because
At the
it's
rectum.
right there at the exit, and it's blood coming out. The dark tarry stool is referred to as upper GI bleeding, because the bleeding is happening higher up in the digestive tract, and it's got a long time to get its way out. So those are the things. Vomiting up the coffee grounds, that is a upper issue as well. What do we do for them? How do we deal with GI bleeds?
Put in NG tube.
Do we do that? Do we do that?
No.
What do we do for them?
Typically give them fluids if they've been
Large
bleeding
bore
for a
IV.
while.
Okay. So manage. This is going to be one of those
What's the treat
things.
for shock?
Treat for shock, manage signs and symptoms,
Keep them
and
warm.
and typically the answer would be IV fluids if they've been bleeding for a while or bleeding a lot without this being addressed. And we'll deal with that by blood pressure and all of those other shock type of things. So that's it. What else goes with GI bleeds? You guys haven't talked about it.
Say that again.
I said, what else is associated with GI bleeds? You haven't mentioned it yet.
Like a sign or symptom.
Hypotension.
It's a sign for you that you can recognize it.
Oh, rectal bleeding. No.
Now, it typically comes with a very a unique smell.
Oh,
You guys, when you smell that GI bleed, you will remember it. So, just saying.
I actually had one the other day, so I know exactly what you're talking about.
You know the
Mhm.
smell I'm talking about then.
mm-hmm.
Mm-hmm. And so your book in the chapters, it goes through a quite a bit of intestinal and abdominal issues, appendicitis, diverticulitis, bowel obstructions, constipation, hemorrhoids, all kinds of things, foreign body
Ulcers.
ulcers, gallstones. You get a ton of things in here. So for assessment, as far as assessment goes, how are we going to check these folks out? What do we want to know, or what do we want to do?
Well, you want to know the vital signs.
A good like history taking and like sample would go a long way with that.
It will. Sample questions and OPQRSTI questions are going to be probably a difference maker in this, more so than the physical exam. With abdominal pain, if we're dealing strictly with abdominal pain, you can palpate the 4 regions. And when we do that with abdominal pain, typically we start farthest away and work towards where they identify the pain to be. So, but more so than just palpating for pain, all of that detective work into questions, history, medications, lifestyle, those types of things are probably going to do much more for you in your assessment than just feeling their stomach and pushing on it to see if they wince in pain or not. A lot
If you're
of these,
listening,
yeah.
sorry, I didn't mean to cut you off.
Go
If
ahead.
you auscultate their abdomen, what are you listening for? Because I know people do that.
You're listening for bowel sounds. When your intestines are actually making noises, and you should hear those sounds in a time frame of like 3 to 5 seconds. You know how your stomach growls when you're hungry?
Yeah.
Yeah. Well, it won't be that pronounced, but you can actually, with your stethoscope, listen around the abdomen, and you can hear noises coming out of the intestines as they're working through the digestive process. So
I also read that like if they have aortic aneurysm, you can hear it sounds like you can hear like fluid moving through a tube or something.
yeah,
I don't know how pronounced it would be.
well, I can tell you when the aneurysm is quite pronounced, you'll actually see the deformity in the abdomen. So it will be a protrusion in the abdomen, and it will actually be pulsing, because as the aneurysm grows, blood is flowing through the aorta with each heartbeat, and you will actually feel the pulse in that thing. That's bad, by the way.
Yeah.
There's also a section on bowel obstructions. So this is, where there's a blockage in the intestines due to some reason. There's a lot of reasons for bowel obstructions. The intestines can actually become twisted and crimped off. There could be a tumor in there that's blocking things up. There's a variety
It's
of
not a
reasons.
tumor.
It could be a tumor. There's a variety of reasons for it. The reason I bring up bowel obstructions, and it's just for your knowledge because I don't know that anybody's using the medication, but one of our medications that we've been given and gone over is contraindicated in bowel obstruction. So anybody want to take a stab at this bonus question?
Aspirin?
Not aspirin. I think it's a medication that nobody has on the truck right now.
Nitrous oxide?
Yeah, nitrous oxide. So you guys have that in your formulary, nitrous oxide, as a pain management tool. I don't believe anybody in this area is carrying it or using it, but it is contraindicated in bowel obstructions and in pneumothoraxes. Any reason you guys want to guess why?
It's air
Slow.
going in.
Hmm?
Positive pressure going in.
It's administered in the form of a gas. So that gas is actually being inhaled and it's going into the body. So as it moves across these membranes and spaces, it is a gas. It is expanding. So if it crosses, as it crosses, not if, because it does, as it crosses into the intestines, it's expanding. So if there's an obstruction, it's actually going to make the obstruction worse. Same in the chest cavity. That gas is expanding. If it's expanding in the chest cavity, it makes the pneumothorax worse because there's less space for the lung to operate in. So contraindicated for both of those situations if you guys ever get nitrous on the trucks again. But something to think about. So if you have a patient presenting with, and things in, really abdominal pain is going to be different, but your choices are going to be different between male and female patients. So if you have a male patient presenting with right lower quadrant pain, give me 3 possible reasons why.
Appendicitis.
Appendicitis, that's the easy one. That should be the easiest, obvious, and first choice. What's the next one?
Diverticulitis.
What was that?
Constipated.
I got constipation. What'd you say, Mark?
Kidney stone.
Kidney stone. Okay. So appendicitis, constipation, kidney stone. There's more reasons for it, but that's 3. So I'd like for you guys to get into the habit of thinking in 3s for a lot of these things. If we switch the patient to a woman, what possibilities, and let's say we can't use the 3 that we just used, 3 more possibilities for a woman having right lower quadrant pain.
Ectopic pregnancy.
Pregnancy.
Okay, so I heard ectopic
Pancreatitis.
pregnancy. What'd you say, Crystal?
Ectopic pregnancy.
Pancreatitis.
Pancreatitis in the right lower
Ovarian
quadrant.
cyst.
What?
Ovarian cyst.
Ovarian cyst. So ectopic pregnancy, ovarian cyst. Is pancreatitis going to show in the right lower? Does anybody know?
There'll be more.
No,
upper
it
right.
shouldn't. Not in the right lower. This is referred pain. It
Okay.
shouldn't. They could have a bladder infection too.
Hey, what's that thing where they walk funny? Like they have a shuffling gait. Stop laughing at me and answer me.
What's that thing where they walk funny?
This is being recorded. I need to behave. Can you please
Yep.
tell me?
Yep, it is.
Isn't that something to do with inflammation around the uterus?
Yeah,
The casing around it?
yeah.
I
What's
forget
that
the name
called?
of it. I don't know, I'll guess and say parametrium.
You'll guess.
Yeah.
I thought it started with a P too, but I can't think of what it is.
Oh, I know peri means around.
Yeah. Around the nutrium, right?
Yeah. I told you it was a guess.
Yeah. All right. So actually pancreatitis will be like mid-range. So like mid abdomen level. So you probably could define that or mix that up between upper or lower. And it could fall in either category.
It's PID, the pelvic inflammatory disease.
Pelvic inflammatory disease, along with a lot of the female problems like endometriosis, things like that. Those are going to be lower quadrant pains and very painful. So this, you'll find the women in the fetal position, they will be showing extreme pain, not like, oh, it's a 10 out of 10 while I'm texting my friends on my phone, but it's a 10 out of 10 like it's killing me. So you'll notice the difference and you'll see those. So those are some good things, but lots of changes between the two. So depending on which sex your patient is, it changes what some of your processes are for questioning, and it changes some of the possibilities for the cause. So make sure in your assessment that you're cluing in on those things. And just remember, in today's world, some people think they are not what they are. So you need to figure out which one they actually are, because that will steer how you figure out what their problems are. Just because they think they're a woman doesn't mean that they have pelvic inflammatory disease or endometriosis or ectopic pregnancies. They can
Men can have periods too, didn't you know?
They can wear dresses, but they can't have those other problems. So there's no need to ask them when their last menstrual cycle was. All right. I'll tell you the biggest thing that I'm seeing with abdominal stuff is actually intestinal problems, and more intestinal problems are popping up. I know several years ago, probably 15 or 20 years ago, you didn't hear much about these intestinal issues. People having Crohn's, people getting a lot of their getting sections of their bowels taken out. That they're doing a lot of that now, where they're resectioning, they're cutting out pieces of dead intestine and then resectioning them together. A lot of people ended up with J pouches or with colostomy bags, this type of thing. I'm seeing more and more of it. It seems to be more prevalent than it was. I don't have a real good reason for it. Like, I've got a real good reason for why I think a lot of kids have asthma now, but I don't have a real good reason for what I'm thinking is going on with these intestinal issues. I know the food companies are screwing with the food, and so a lot of the foods we eat have been, especially processed foods, there's no telling what's in there. There's a lot of preservatives and different things, but I just don't know if that's got anything to do with it, lifestyle wise, what's doing it. So anybody have any thoughts on that?
I'd have to agree with you on the processed food thing.
Yeah, I think it's all the food companies messing with the food.
Also, I was reading a paper about how the tap water in like 10 of the biggest cities across the United States had pretty high levels of contaminants that are extremely bad for you.
Mm-hmm. And that may be,
Now they've even changed the chemical pesticides that are being sprayed on even your natural grown food like corn and berries and stuff like that. They've even changed that thing that they're being sprayed with.
yeah, I mean, it could be like drinking water as well, because I know a lot of things are getting in there and our bodies, some heavy metals and different things that our bodies just can't deal with, process or digest or get rid of even. You know, we know they're hormoning up the chicken and different things. And I got to tell you, when they pump a chicken full of hormones and grow that thing from birth to full grown in like 6 weeks, just because they kill the chicken, the hormones are still there, and the people that are eating it are getting those hormones. And that's why our kids are hitting puberty now at like 8 years old and 10 years old. So, but the intestinal part, I am seeing a lot more intestinal issues. Crohn's is probably the biggest one. There's a lot more like diverticulitis and stuff out there. So, and I'm seeing a lot of people with sections of their bowels that are being removed because they're saying it's no good and all. And you know, we're doing colonoscopies and we're doing endoscopies and all these things, so they're checking it out. They're finding these problems, but I'm just not real sure what the thing is, the lifestyle is, or anything. I don't know that alcohol is really the reason. I'm not sure we're drinking more than they ever did when any other period in time. Alcohol's always been around, 15, 16, 17, 1800s. It's always been around. So I don't know if we're doing it more or if anything's going on with that. So if you guys run across anything or any thoughts on it, just let me know what you think. What's going on with this?
Well, I can tell you right now, Crohn's hurts because I'm newly diagnosed with it. So
okay, and that is true. It is quite painful. Crohn's and diverticulitis, you're going to see some painful issues there, and but that is a long-term. I mean, that's going to be a long-term chronic battle. They've got some medications that seem to be making some progress with people, but it's always changing. It's kind of one of those weird things, like if you're battling like a broken thyroid or something, you're going to have to change a few of those. But a lot of it is diet induced, I think, with the flare-ups and the pain and stuff. So you be careful with that. Did they give you like a diet to follow or anything?
I was supposed to be doing clear liquids until I went and had my was.
Okay, so clear liquids for now, and then once they get a look at everything and see what's going on, they'll let you know.
Yeah, like you were saying, there's medicine that actually helps with it as well.
Yeah, they've got some high powered stuff, and it's along the lines of actually like rheumatoid arthritis and that sort of thing. So the same medications are treating it, but it is a painful process, I can tell you. Debilitating when it flares up. You won't be able to. You can't play through that pain. So you'll know it when it happens. Same with the gallstones. People that have their they have their gallbladders removed because of gallstones, and that's a diet change for a lot of people because the gallbladder helps to break down the fats and deal with the fats, and so once that's not there anymore, those people typically have a hard time with like fatty foods. They will have like some explosive diarrhea and things like that. So if you don't have your gallbladder, let me know if you haven't experienced that. If you know people that are having it taken out or having it removed, they typically can't tolerate the fattier foods and fried foods because it will just work on them.
My older sister had hers removed when she was in high school,
Okay.
and she doesn't handle that stuff well. And she was actually just recently diagnosed with Crohn's as well.
Oh yeah,
And
so she went from bad to worse.
When she got it out in high school, and she's now in her late 30s.
Okay.
And now she's developed this minor Crohn's
Okay.
syndrome, and from what she describes it, it's very painful.
Very painful, yes. So just be on the lookout for those things. Diverticulitis, there's some little in your intestine lining, there's some diverticuli pockets, and those things will get food particles trapped in them, especially seeds. If you eat foods that have small seeds in it, like strawberries or cucumbers, things like that, tomatoes, those little small seeds will get in there and get stuck, get infected, inflamed, and then that diverticulitis will occur. Also extremely painful. These people will be presenting almost into a sepsis type of state because it is an infection. So you'll see that, but an incredible amount of pain. So if you know people with diverticulitis that have had it, they're on a no seeds diet, so they shouldn't be eating anything with seeds. All right, that'll take us into the next chapter, which is the renal system and the reproductive stuff. So number one organ to die first, and you not, is the kidneys. So what are the reasons for kidney failure?
Hypertension.
Hypertension,
Diabetes.
diabetes. These are uncontrolled conditions, by the way. Uncontrolled
Right.
hypertension, uncontrolled diabetes. What else?
CVAs.
One more big one.
Alcoholic.
Well, that
I
might.
gotta work on the liver.
That's not
Is
that's
it-
not what we're going for.
The NSAIDs.
Medications. Yes.
Oh.
There's a lot of medications out there that people are taking, and
Mhm.
whether it be short term or long term, those medications are actually killing their kidneys. So typically now, as a general practice, when a doctor starts you on a medication, after you're taking that medication for a short time, it could be a week or 1 to 2 weeks, they'll want you back into the office to do some blood work, and they want to see how that medication is affecting your organs and your functions. And so then after that, they're going to periodically do blood work to make sure that nothing starts getting out of whack because of so many issues, especially with the kidneys, liver, those types of things. And who knows? I mean, some of these medications, it may have some effect on these intestines and the issues that we're seeing. But those are the big things. So, biggest issue with dealing with kidney failure, people are put on dialysis, right? Most are not going to get a kidney transplant. There's a lot of people that need kidney transplants. Most will not. So while they don't get them or while they're waiting, dialysis is the answer to keep them alive. So that is how they get the toxins filtered out of their body, is through dialysis, since the kidneys aren't working anymore. There's two types of dialysis. I hope you guys are familiar with both. I know you're familiar with one, especially if you're at an agency that does non-emergency transports. What's that type of dialysis?
Hemodialysis.
Yes, hemodialysis, where you have to go to the dialysis centers. They hook you up to the machines. They filter your blood, is actually what they're doing. They reroute your blood out of your body through the machine. It filters it, and then they put it back in your body. Sounds fun, right? Usually about a 3 to 6 hour process, depending on your level of filtering that you need and how much they want to work that day. So what are the problems associated with hemodialysis?
Low blood pressure.
Low blood pressure.
Hypotension.
What else?
Dehydration.
Okay.
Issues with the access site.
Yeah. Bleeding issues there at the access site. What medication are they giving these people to keep their blood moving? Do y'all know?
Anticoagulants.
Yeah. Do you know specifically what they use?
Again, I'm gonna guess and say warfarin.
Most of the time it's heparin that they're using. When they start the treatment, they'll put heparin in, which will keep the blood from clotting and keep it moving through the machines. And when they stop the process, that's why they have to hold that pressure for a while. They've got to get that heparin out. They've got to get that blood stopped, and it takes a while. If it's a bleeding complication, typically what you will see is when these patients get out of dialysis within, I would say usually probably within the first hour, that site may start bleeding again, and the patients may have trouble controlling that. So if you get called to a dialysis patient that has been out of dialysis for an hour or two, that's probably what's happened. That site started bleeding again, and they can't stop it, and that could turn fatal for them if they wait too long to call you, or if you're not able to get control of that thing. So yeah, hypotension, dehydration, bleeding at the site, and just sometimes just a general feeling like crap because the machine pulled off too much. They just got their electrolytes kind of out of whack. So it may take them a day or so to rebound from that and feel better. The other type of dialysis, less known to us because it's done at home. Do you guys know what that's called?
Peritoneal.
Peritoneal dialysis. They actually put a catheter in the abdomen through the peritoneum. And what they do is they pump fluid into that space, and they use the peritoneum as the filter. So, and it's based on a pressure change. So they'll pump in a bunch of fluid, and then the toxins out of the blood will flow to the lower pressure, which will be in the peritoneum, and then they can pull all of that out through that catheter. So much slower process, not nearly as efficient or effective, but it does allow people to stay at home all the time. Hemodialysis is a definite lifestyle change. You're doing that every other day, 3 times a week, half a day each time. You're spending quite a bit of your life there doing that, where the peritoneal dialysis will allow you to stay at home at least, but just not quite as effective or efficient. Urinary tract infections and kidney stones. Let's talk about those. Urinary tract infections. Who's more susceptible, men or women?
Women.
Women. Why? Because we don't like women?
Sometimes they don't wipe properly.
Nah, that's not the reason.
Because they don't wipe properly?
Although it's probably a factor.
You gotta wipe front to back.
It's just a simple thing that deals with anatomy. What is it? What'd you say, Derek?
Shorter urethra.
Yes. That's it.
Their anatomy is much shorter than ours.
That's it. It's just the length of the
Some of 'em.
urethra. Yeah. Make your jokes. All right. So a simple length of the urethra is the number one causing factor for more UTIs in women than in men. Now, hygiene might have a lot to do with it. Hygiene, lifestyle, those types of things could affect it a lot, but the number one factor is just the length. So you're looking at 3 to 4 inches in a female as opposed to 7, 8, 9 in a male. These are averages, by the way. And most of that is internal, not external. So don't get thrilled, guys. But that's the cause. So UTIs, what do those patients look like?
Just back pain and abdominal pain.
Okay. What else? What did you say, Chris?
Altermental.
In the later
Older
stages,
patients. In older patients.
yeah. In the later stages, yeah. Initially, it's going to start out as pain. Typically, you'll have that lower abdominal or bladder pain with the UTIs. If untreated, it could lead into a sepsis type situation. You'll start seeing fevers, altered mental status, those types of things. What about the urine?
Odor.
Yes.
Cloudy.
Just like with the GI bleed, you will experience a smell that you probably won't
Will
forget.
not forget. Oh yeah.
Or want to smell again. So just be aware of those things. Typically more often in females, especially elderly females. And that's what you'll see. So it in the specific of the sexes, in the male sex, there's an issue called priapism.
Mm-hmm.
Anybody want to explain that?
Usually a result of a spinal injury, and you got way too much blood flow going to that organ.
Okay, that's a telltale for a spinal injury. Yes.
Mm-hmm. Mm-hmm.
What else? What else can cause it? Not a spinal injury.
Too many Viagra and not making that phone call after 4 hours.
There you go. Erectile dysfunction drugs can cause it as well. So you know the commercial. If you experience an erection for more than 4 hours, you should seek medical attention. That's the one. So So again, it's going to take a little bit of investigation as to what the cause is, but you'll see it. That's what the issue is. Blood is actually trapped in the penis, and it can't drain out, which is why it's happening. So we're trying to get blood to drain out. So what's a treatment for this?
Well, when we take them when they get them in the hospital, you have to draw it out with a needle. The doctors do.
We're not doing that in the field. What are we doing?
Keeping them comfort. Put them in a comfort position and bring them in the hospital.
Ice pack.
Ice packs. Yep.
Yeah.
Give them some ice packs there. What do cold things do? What does our body tend to do when it gets cold?
Shiver.
Shiver. What else?
Shrivel.
There you go. Things tend to constrict. They tend to get smaller. It could help. So ice packs is about our only option. From the female side, they have a few more parts than the men do. So ovaries, fallopian tubes, uterus, those types of things, they're all in there. So when we're dealing with females, especially with pain, first of all, we want to consider, first question, are you pregnant? Could you possibly be pregnant? Right? How do we know if they are or not?
We can't.
Menstrual cycle.
Menstrual cycle, good indicator if they're telling you the truth. Really,
Right.
the only way you're gonna know 100% is lab testing, but we don't do that, so we have to take them at their word. But menstrual cycle would be the best indicator. So typically, what's the time frame after the cycle before they can get pregnant?
Is it 14 days?
Okay. So, at least a week, probably 2. When they hit that 3rd week, that's a prime time. And then up until the cycle starts again. So watch out in those last week or 2. That's the highest probability. Pain for them, typically we're going to think ectopic pregnancy first. If they do have one, endometriosis is another condition that is quite painful. And then as Crystal said earlier, ovarian cyst and pelvic inflammatory disease, all of these things specific to the women and all generate a good amount of pain. And then for both sexes, it talks about, your book is going to talk about sexually transmitted diseases. So a lot of things in there, different infections that you could get from having not clean partners. So if you're single and you're exploring, be careful. And if you're not single and you're exploring, be careful. Probably be more careful. And see what happens. So your book's going through a bunch of them, chlamydia being one of them. The fix for that is doxycycline. Anybody want to take a stab at what else doxycycline fixes?
UTI?
Probably. UTIs, sinus infections, and
Lyme disease?
and your chlamydia. It's a well-rounded antibiotic there.
Mm-hmm.
Anybody have any questions about renal diseases, issues, problems, or anything dealing with the sexes? No. The last chapter is 26. That's the hematology part. So this is going to be issues with the blood. Again, some A and P at the beginning. Your book is going to discuss the different cells in the blood and what their function is. There is a very interesting chart on page 654. If you guys haven't had a look at that yet, you should, because it's quite interesting. It's a list of things that affect blood clotting. So you should say aspirin, right? Because aspirin affects blood clotting. But this thing has a list of like herbals and vitamins and other things that can affect blood clotting. So that would be probably some good information for you to know, taking care of your patients. Did you know that alfalfa affects blood clotting? Anybody? Alfalfa?
What is
What about-
No
alfalfa?
idea.
What about garlic?
What is alfalfa?
It's like a grass. You can eat it. It's a food that you can eat. But garlic and ginger, vitamin E, vitamin K, these types of things. So, no doubt warfarin's on the list there, Mark. So, but pretty interesting, some of the things that are on that list. Worth taking a peek at. So what are some blood disorders we may have to deal with?
Sickle cell.
Sickle cell. Somebody said sickle cell. Explain what that is. Do you know?
Abnormal shape, red blood cells.
Yes, they are shaped like sickles. So instead of being round, which typically the blood cells would be round, they get a sickle shape. And when they start this process, it becomes extremely painful for the patient. When those cells start to sickle, as they're still circulating, and it is quite painful. Who is susceptible to this? Most susceptible?
African Americans.
Yep. African Americans is what we'll see predominantly. It does affect Middle Eastern folks and like Central American type people, but more often than not, we're going to see it in the African American population.
It's a good picture on 658.
Yeah, there is. They have a good picture of the shape of those cells. Treatment for us, what's the treatment for sickle cell when they start to have an attack?
Fluids.
Yeah. Mostly supportive care. IV fluids are indicated here. So unfortunately, we just can't really do much for their pain until that process is stopped.
Would Toradol be a contraindication? Would it be a contraindication? Wait a minute. Contraindication for Toradol? For Toralac? Hi, Cleo.
I don't. There's better pain management in the medic world, but if you are the only provider, it may be all you have. So it probably could be a choice for you. These folks are not likely going to surgery. This is a process that starts and stops, and it's just painful in between. So the Toradol just may not be strong enough. That's the only thing. But it's all you got, so. What other
Leukemia.
what's leukemia?
It's the cancer that causes the bone marrow to rapidly produce large numbers of abnormal white cells, white blood cells.
Okay. So this is from white blood cells. And so this is a blood cancer because it's happening in the white blood cells. And so there are quite a few people that have leukemia. It is, I'm not going to say treatable, but they are making progress with it. Anything we're going to do for these folks?
IV.
Yeah, another supportive care type of thing. Not really anything that we have a treatment for.
I don't really think someone would call 911 for rapid onset leukemia or something.
No. Typically, they're going to have some other issue. The leukemia is probably going to be one of those things that they should know about if they've been diagnosed. The only time that it may be unknown before diagnosis, they just don't know they have it yet. And the signs and symptoms for it are usually bruising, bone pain, obviously swollen lymph nodes, constantly being sick, frail. These people are probably small.
And
So
fatigue.
yeah, tired, weak. But if they're having all of those things, if you're noticing all of those things in your assessment, it could be something to be highly suspicious of if they haven't already been diagnosed with it. But usually we're not the ones finding cancer with EMS calls.
Right.
Okay. Let's talk about blood clotting disorders for a minute. What are some blood clotting disorders?
Hemophilia.
Yeah. Hemophilia. So those are bleeders. Their blood just will not clot. They don't have the ability for those things to stick together. So when they start bleeding, they bleed more freely. It takes longer to slow down and stop. A lot more pressure, a lot longer time frame. That sort of thing. We have that. So, anybody familiar with a medication that helps, that can be administered that helps to stop bleeding? It's not a medication that's in your formulary. It is in the medic formulary, but
TXA.
TXA,
Stop.
yeah.
Quick clot. Oh.
No, not quick clot. TXA. is an actual medication to administer. And there are some people, some agencies that are carrying this
And,
for field use.
Isn't I heard Chowa was using it now?
Yeah, they do have it. Although I asked the other day and they said it's out of stock right this minute, but
Actually, the other day I was looking in the drug box and we had some.
You saw it?
Yeah.
Okay. This is what I want you guys to do for the rest of the from now until lab time this week. Do a little work looking at TXA as a medication, what it does. You don't have to memorize dosages and routes and things like that, but just look at what it does in the body and some indications for use type of thing, and when you come to the labs this week, just be prepared, have a little background knowledge on it, be prepared for like a semi-intelligent conversation about it. Again, it's not in the A formulary, it is a medic drug, but interesting what it does and what it can do, and that it's being deployed out into the field now. So just a little light reading for you for the next day or so. Blood clots is the last thing. So typical, our biggest blood clot issues, where are they? 2 places.
In the lungs.
Lungs, we call those PEs.
And the head.
And the where?
Your head.
Extremities.
Extremities, DVTs in the extremities. Yeah, you said the head, that's a stroke. I get it. But non-stroke related, typically we'll find them in the lungs or in the extremities, most of the time in the legs. So DVTs and PEs, prominent clot places. If it's a DVT, what are the signs and symptoms for that thing?
Swelling and redness.
Okay.
And warm.
Swelling, redness, warm, and pain. Those are the things you're going to see as a DVT. If it's a PE, what are you going to see?
Shortness of breath.
Yep. What's the onset?
It could be sudden onset. I mean, you could just be like.
Yeah. It will be a sudden onset shortness of breath. That's what you're going to see with the PEs. So sudden onset shortness of breath, and then the other in the legs. If we're dealing with a clot in the head, they are going to be presenting with stroke-like symptoms and should be positive for their stroke screen. So good job there. All right, so that is your 3 chapters. Anybody have any questions? No. Yes, no.
No, I don't.
No.
No, sir.
Okay. Cool deal. We have labs this week. Remember Perquimans and Elizabeth City, that's where we're doing them from now on. So you should be at one or the other. If you didn't pick a site yet, shame on you. Right?
I think while we're on the subject, I think for not next week, but the week after, we're not able to select, or no, we are able to select a lab site, but it doesn't unlock the next week's. It's like something weird on my courses.
Oh, I see what you're talking about. Thank you. That's fixable. I can probably even fix that myself. All right, I'll take care of that. So you guys remember stay on top of the online work that's in here each week. You've got some chapter quizzes, you've got a discussion, and then whatever else might be in there, your self-assessments, lab sites, those type of things. Make sure you're picking those on time. Make sure you're getting all the work in on time each week. So it's due the week that it's scheduled, and then and get it in.
Are you going to be in Elizabeth City this week?
I will not. I won't be at the lab this week. So there will be, you guys will be filled with knowledge by other knowledgeable people.
If I don't think I'm going to be able. The reason why I asked is I would have just asked you then, but I don't think I'm going to be able to make it to lab next week. Is there anything I can do to make up for it?
Which week?
Not this week, but next week. The 12th and 13th.
Or an event.
We're allowed like a certain amount of hours absence, right?
Yeah, 20 some hours.
Okay. I think I'm at 0, so I'll be good.
Yeah, you'll be fine.
Cliff, I'm gonna go ahead and tell you we're going to Larry's in the morning.
We are?
Yep, yes, sir.
Hey, did I tell you I'm not going to be there till 8?
Wow. Well, I'll wait until 8 then.
Okay. Just so you know, I'm working tonight, so I'm going to be late getting there. I told them I wouldn't be there till about 8 or just after 8. So, just so you know.
Well, you know you're on the truck with me.
Oh,
Huh?
slacker.
Shut
Hey,
up.
who's teaching tomorrow then?